Hi, my name is Xuan Le, Senior Advisor at the Bureau of Primary Healthcare at the Health Resources and Services Administration. I'm here to share with you a live demonstration provided by the winner of our Bureau's very first prize challenge called Building Bridges to Better Health, in which I served as a technical advisor on the planning team. With this challenge, we crowdsourced solutions from just about anyone with a good idea on how to address those non-medical social health related needs that have a significant impact on our overall health and well-being. And we did this with a particular focus on underserved communities in a primary care setting. The challenge ran for over a year and leveraged design thinking as a framework, structured in 3 phases that included ideation, prototype development and testing, and scaling for the potential spread and adoption across the health center program. Our first place winner was Washington County Mobile Integrated Health Network, based in Missouri. Justin Duncan, founding partner of the network, is featured in this video on a webcast with our Bureau's Associate Administrator, Jim McRae. Their proposal stood out from over 100 submissions we received in total. So we hope you enjoy the demo, get inspired so that you can take away some ideas for how you can partner within your community to better address the needs of underserved populations across the nation.
Good morning to those out, I guess, in the Central Time Zone or West Coast, but just most importantly, just really thrilled to have you here with us today. For all the teams that are competing in our last phase of our Building Bridges to Better Health, a Primary Healthcare Challenge, which is really, as you know, focused on how to scale your solution that you've provided to us. And really just want to thank you for making the time and congratulations on your work to date. As many of you know, this was actually our first prize challenge that we've ever had here in the Bureau of Primary Healthcare. It's actually something that we had been wanting to do for a number of years to really, for lack of a better word, crowdsource and fund the best ideas to better connect our health center patients to primary care and social services that we know impact their lives. As you all also probably are aware, it's now almost 60 years that health centers have been around providing high quality, affordable, comprehensive primary healthcare services for their patients. And right now we're serving almost 30.5 million people across this country. And what we really, of course, value about the program is that it's, of course, high quality care, but that no one is turned away. And today we have about 1,400 health centers supporting about 15,000 service delivery sites in every U.S. state, territory, and the District of Columbia. So we have a broad scope. So your projects to help us do that better connection between primary medical care and social services is so important. In addition, just last week, we celebrated National Health Center Week, which is really a week-long celebration of the program, bringing together thought leaders, innovators, leaders of the program itself to really highlight some of the amazing successes. And I'm really pleased to say that having read some of your proposals already and looking forward to the presentations, you being a part of that family with us. Most importantly, though, what we want to do, of course, is lean into the innovation space to position health centers to continue to be, and maybe even more so, leaders in primary healthcare. And for us specifically to build more relationships, not only within the federal government, but outside, to really, again, serve as that critical link between primary medical care and critical social services such as transportation, food, and housing. I, of course, also like the challenge model because we can be more creative than we are in our traditional funding opportunities and utilize this Shark Tank top model to get and identify new ways to address the health-related needs of our patients and their communities. But before we get into the presentations and what we hope really will be an active dialogue between us and conversation is, I really do want to thank all of our challenge advisors and the HRSA challenge team for their time and thoughtfulness in designing the challenge and reviewing the proposals throughout each phase of the competition. They did this in addition to their day jobs, and they really did it out of a commitment to making sure that health centers and the people we serve get the best services that they can. So I also want to thank my fellow judges. They've taken time out of their very busy schedules to be part of this. and I really want to thank them for their engagement. I will say this personally, we've really enjoyed the entire process going through phase 1, 2, and 3, and really look forward to hearing you today. We've had the opportunity to brief glancely at your different proposals. Actually, in some cases, like I read them very thoroughly. I'm sure my colleagues did too. But really today was about hearing from you about what is important about your proposal, how you think it's important for the health center program, and how you can take it to scale. So we're really excited about that. We know this has not been probably the easiest part in reading some of the proposals. This is probably the most challenging part, is how do you take a good idea and begin to scale it? And so we want to hear about some of those challenges, but we also want to hear about how you think you can take it to the next level in terms of scaling this. Also, just at the very end of all of this, want to encourage each of you to complete the participant survey. Our team will be looking at those results and recommendations to make improvements in any future HRSA challenges and the health center program itself. And again, lastly, just want to thank you personally for the time and the effort and really the creativity and innovation that each of you showed in your projects. You always do one of these things and you wonder how it's going to be. Well, you surpassed my expectations in terms of what we could potentially accomplish through this prize challenge. So I just really look forward to that and look forward to hearing your pitches and wish you a lot of luck today. And with that, I'm going to turn it back over to Jamie to get us started.
We used a variety of different factors to identify our winner. Half of our winners focused on technology solutions, and the others focused on partnerships. And I'm really pleased to announce that our guest speaker, our first place winner, Justin Duncan, works with the Rural Mobile Integrated Healthcare Network. Basically, they successfully spearheaded a partnership with HRSA-funded health centers, emergency medical service agencies, local public health agencies, and social service organizations to provide care to high-risk and chronically ill patients in their homes, significantly improving their health outcomes. The MIH network achieved a 50% reduction in Medicaid and Medicare costs in Washington County, Missouri. Patients also saw improved clinical measures, higher rates of preventive screenings, and better managed blood pressure compared to health center patients who did not participate in the network. I will just tell you, when Justin presented his proposal, I couldn't show it to the other judges, but I leaped out of my chair because I was so excited to hear about what they were able to accomplish and really some of their ideas about how to take this to scale in Missouri. And I would ask Justin to be willing to also help some of our health centers in other states think about this type of partnership. So Justin, I'm going to give it to you, and congratulations to share your proposal and what you were able to accomplish.
Well, thank you very much, Jim. I'm actually in South Dakota currently talking to folks here. And you can go to the next slide if you'd like, please. I am very proud to represent the Washington County MIH network. We are unique in that our primary partnership is between an emergency medical services agency or a paramedic service that I represent and a federally qualified health center, which is Great Minds Health Center. We are the first type of partnership of such in the country that we have found yet. And we are happy to show that we can take care of sick people, we can make them better, and we have expanded. Our third primary partner comes from Community Asset Builders out of the Jefferson City, Missouri area. And they are a resource development organization that help us navigate, and they're connectors. We're proud to have massive partnerships with our state offices of rural health, primary care, chronic disease, to really take healthcare outside of brick and mortar and into the patient's environment. There is that subsect of patients that they're just not going to make it to brick and mortar, and we can leverage our resources to take the care to them. And that's really the highlight of our model. We have massive partnerships across the board with other primary care providers, with specialists, with public health. And the uniqueness is that the health center brings the clinic provider, they bring us resources of specialists, they bring labs, they bring imaging, and I bring a licensed paramedic that has an endorsement on their license as a community paramedic. And we take what we've traditionally done for emergent care and we've shifted it to preventative and primary care. We utilize community health workers as not only our mission control in the background, but also all of my community paramedics are community health workers. And we've expanded this model across the state of Missouri and hopefully moving across the country. There's multiple entry points, whether it's self-referral, provider referral, hospital emergency department discharge. But one of our greatest referrals are our paramedics on the 911 side of the house who see these chronic patients over and over and over, utilizing the emergency department as their primary care provider. We can facilitate exams and assessments in the living room. We draw labs. I can result in A1C for diabetic patients in their living room. We do EKGs, ultrasounds, in-home infusions. The list goes on and on and on. And then we facilitate a telehealth visit. I know that telehealth is an amazing tool, but the reality in the rural areas where I hail from and much of the country, there's not access to broadband. So we bring it to them, utilizing our public safety models of being able to access broadband capability in folks' living rooms. The providers love it because now they have a licensed clinician with eyes and ears touching patients who can actually do intervention and physical assessments on their patients. Next slide. This is an example of a vehicle that we utilize in our fleet. You'll notice it's outfitted with standard paramedic equipment in the event that they do encounter a true emergency. They also then have an iStat, so that's what the refrigerator's for. They can do point of care lab testing and a plethora of other items based on the needs of their patient, everything from vaccine administration, blood draws, to new diabetic education and helping somebody navigate their disease process and become compliant. We help our patients enroll in health plans, in Medicaid, and provide good old-fashioned resource navigation of the system that's not always easy to navigate. Next slide. So of course, we want to tie it to quality. I'm still a licensed clinician and a paramedic by trade. My heart and soul is in patient care. I never dreamed that I would be a boss, let alone talking to folks at HRSA. Also didn't know what HRSA was about 4 years ago. So I am definitely learning and I have unbiased eyes that I can say we've likely should have all been working together for a very, very, very long time, and it's time to break down those silos. So from a quality standpoint, taking it from anecdotal, we took the quality measures that our clinic already tracks, and then we put them up against our MIH cohort. And as you can see, diabetic is a fantastic opportunity to start. Uncontrolled A1Cs or untested were a barrier that was identified early on. And we're proud to say that all of our patients are compliant in that realm, meaning they're getting their tests or we've been able to control their disease. Next slide, please. We have a plethora of other quality measures, of course. We track all the HEDIS measures as required for our health center, and we've applied it to our practice as well, just as a good way to show what we're doing. And things I never dreamed of, foot exams, eye exams, depression screenings, those care gaps have been able to be closed on these patients that weren't presenting to clinic for whatever reason, whether it was access to transportation or they just didn't understand the importance of doing so. We were able to close those gaps. Of course, we look at our local community and we look at the structural intervention to a system that can use change. The definition of insanity is doing the same thing over and over again and expecting a different result. We needed to accept first and foremost that they weren't making it to brick and mortar. It didn't matter why, and then figure out how to close those gaps, get them the care that they need. And then when they need brick and mortar for specialty services, for procedures, hold their hand, bubble wrap them, and make sure that it gets taken care of. This is high touch. There is very little rocket science behind this. And it's a good old-fashioned primary care. It is taking folks who utilize an emergency department for primary care, getting them a primary care medical home. And it's accepting that a patient doesn't care about managing their diabetes or what their blood pressure is if they have food insecurity and they don't know where their next meal is coming from, or if they don't have a roof over their head. And then accepting that there's homelessness in rural areas. You don't have to live in a cardboard box under a bridge to be defined as homeless, that you have places in my community where people live with dirt floors, in trailers with no roofs, and sewer running out into the ditch. And that happens all across the country. And so we must address those social determinants of health and make sure that they have a safe, healthy place to live and to recover, and then work to manage their disease process. We started this adventure with right care, right place, right time. That was our mantra. And then it advanced to diverse, inclusive, whole patient care. And now you'll hear us say diverse, inclusive, whole person care, because you can't just treat the sick piece. You got to make sure that they can be well. And a transition from from a sick care model and a reactive business to a well care model. Common misconception of my business is all we do is emergency work. In my community, about 15% of what we do is true life-threatening emergencies. That might be high. People think I joke when I say over the years, we deal with 911 calls for toothaches and chronic back pain, and I ran out of my meds and I just don't know what to do. I need my blood pressure checked. And so these folks are accessing the system, and now we can loop them in and be the structural intervention to get them the care that they need and become champions in their own healthcare and hold their hand along the way. Next slide. Pre-COVID, there were 6 programs, mobile integrated healthcare programs in Missouri. There are programs across the country. I'm very proud and a little biased to say that ours is the first partnership with a health center with an FQHC. And we now have expanded to not only doing healthcare together. My community paramedics live with community health workers and the clinic providers. We have a joint maintenance program. We're looking at building a joint logistics building, work smarter, not harder. And if you look across the state, we have programs now in multiple counties, urban, rural. And I believe it was Jim who asked me how we were successful with our health center. And I said, well, we were successful with our health center because of relationships and honest conversation. There were no egos. Nobody's better than anybody. We're all here for the same purpose. And Greg, the CEO at the health center, and I very quickly realized our mission, vision, values are the same. We take care of sick people. We fill gaps. Let's try it. Let's see what we can do. And that's a mantra that we've followed through this. And there's now 8 partnerships across Missouri with FQHCs and paramedic ambulance services. Next slide. I was given 5 minutes and I can talk for hours. So I appreciate the time, and we're humbled and honored to receive this recognition, and look forward to seeing expansion across the country.
My name is Nicole Adams, and I'm here to tell you about Bridges to Community Resources. This is a software solution to addressing social determinants of health from primary care. I'm speaking on behalf of my team from Purdue University, which includes Nan Kong and Baijian Yang. Together, we represent nursing, systems engineering, and computer science. On the road to health, we all know the importance of having access to care, particularly primary care. But we also know that things like housing, having access to nutritious food, having social activities and a place to exercise are all important to health as well. And there's a chasm right now between primary care and these social determinants of health. So we sought to bridge that chasm. Our initial goals were to address patient needs and organizations all in one software place. We also wanted to collect a unique data set for social determinants of health research that has individual level data, not just population health level. To do this, we created software to manage social service referrals. In our first release, we created a system where all registered users in a clinic can see patients, referrals, and the resources. We created a system of recommendations that narrows the choices down for what services the patient may need based on their social service screenings. We also created a printout that's professional and keeps patients organized and replaces the stack of pamphlets and sticky notes that many clinics hand to their patients. There's a system to do reminders for case managers so that they can follow up with patients to find out if they got the services they need. And the resources are only those that are actually located in the community, not those that are out of state or hundreds of miles away. We closed the loop on referrals and social service organizations by collecting that information from patients. We find out when they received the service and if it met their needs. And this is from the patient's perspective. So it takes into account that time lag that patients may have related to motivation to seek those services. Our next goal was to improve the usefulness, navigation, and acceptance of our software. So we went back to our pilot site and we made changes to our user interface based on their feedback, which led to release 2, which had an improved layout of the entire user interface, a way to customize instructions to patients on that printout, and the option to add a clinic logo to the printout so it really looks official and professional. Our next goal was to scale to clinics across the state. And we presented to clinics and organizations representing providers at FQHCs across the state of Indiana. We got tremendous feedback on our concept and our user interface. One person said, I don't know how you did it, but you got the system I had in my head for my master's degree and you made it come to life. But there were barriers to using it. First of all, it's not in the EHR. It is a EHR agnostic web app. It is HIPAA compliant though. The other issue is entering all those organizations. Right now, it's a manual data entry process, which is how we get that customization of it's only the resources in your community. And that takes a long time to enter the organizations. And lastly, we asked for 4 health outcome measures, which are those that are reported by FQHCs, so that we could do some advanced predictive analytics and actually put the services that give the biggest impact on addressing health outcomes to the top of the list of recommendations. So people who had a lot of needs knew where to start. This is where our big pivot came. So we went about incorporating with 211 and integrating with EHRs. In Indiana, the Family Services Social Administration covers 211. So we have one agency that does 211 for the entire state. This is going to be coming to life in release 3 with our reciprocal relationship with 211. Not only will we connect to the 211 database to download that organizational information into Bridges, but those organizations that have closed, changed hours, or aren't in the 211 database, as they're entered into Bridges, that information will go back to 211 for review, and they can decide if they want to update their database. But in this way, we give back. We're also in discussions with 2 EHR vendors, Health Call and Athena Health, about integrating into the EHR. This would mean that health outcomes and patient information would auto-populate into Bridges, reducing the need for double data entry. We also would be able to provide back to the EHR information for billing purposes, if and when billing does happen for social service referrals. But these relationships do take time, so that's why release 3 is not finished yet. We looked at our next goal of national scaling with 211 at the national level and the use of Bridges across the country. This will require us to seek long-term funding and support, but we believe the data set we're collecting is of national importance and that we will be able to to acquire some national funding. And of course, we have ongoing support from the Reagan Street Center for Healthcare Engineering here at Purdue. In conclusion, that Bridges is a referral decision support tool that's going to be augmented by machine learning and targeted recommendations for the services that create the best improvement in health outcomes once we have that data. It closes the loop on social service outcomes from the patient experience, not provider metrics. And through EHR integrations, our manual data entry into Bridges, we're collecting the data for social determinants of health research. That EHR integration is made possible by the FHIR standards that have been required since December of 2022. And lastly, that 211 interface only exchanges publicly available organizational information. And not only does it make Bridges easier to use, but we give back and make the 211 system better.
Good afternoon, everyone. My name is Britney Balden, and I am the Population Health Program Manager here at HealthyLink, and I will be presenting our Phase 3 summary. So HealthyLink, the West New York Regional Health Information Exchange, built an innovative solution that we've called Healthy Quality, which surfaces gaps in care and snapshots of important clinical information to assist health centers and other healthcare organizations, with the goal of improving quality of care for their patients. Health Equality was created to serve as an interconnected application that helps break the silo separating clinical care and social concerns that provide barriers to care. The objective of this multi-phase challenge was to develop and test low-cost, scalable technical assistance solutions that can be used by our health centers. Health Equality was developed using SMART framework and a SMART on Fire app that was used by providers to help close clinical gaps. It's also used to address clinical concerns and monitor social services for their patients. So Health Equality, which you'll see in our live demo, has 3 tabs of data. It includes clinical gaps in care, social concerns, as well as pre-visit planning clinical information. Health Equality is currently accessible to through the Healthy Community portal. So for phase 3, Healthy Link applied lessons learned from phase 2 with the goal of really including more information to impact additional patients. So we included 2 chronic disease management measures, hemoglobin A1C for control of diabetes, as well as blood pressure control. This was in addition to the cancer screening metrics that we have included in the tool for phase 2. We selected these measures because, as many of us know, health disparities have been well documented for the selected measures and also are attributed to social determinants of health that impact care. Healthy Link also applied lessons learned from phase 2 and scaled the solution by adding additional health centers. Lastly, Healthy Link also added a new pre-visit planning tab that included clinical data, which includes encounter diagnoses, immunizations, lab results, as well as the social history of a patient. These scaling goals for phase 3 help expand and reach additional patients and ultimately have a greater impact on overall patient care. So in this solution, throughout this project, we were really keen on identifying and understanding the populations that we're serving. So we identified the patients using the metrics that we have included in the tool as patients who did not have cancer screenings completed, as well as patients who needed follow-up or needed testing done for their diabetes, A1C control, as well as their blood pressure. These health centers that we selected to be involved in our program serve impoverished communities throughout Western New York. The poverty percentage for Chautauqua is 28% for their major city, Jamestown, as well as for Cattaraugus, their major city, Olean, currently has a 28% level of poverty. Jericho Road, one of our health centers participating, also serves one of the poorest zip codes in Buffalo, whereas 1/3 of Buffalo residents live in poverty, which is among the highest in the nation. The use of Health Equality was designed to address these health disparities by providing clinical and social determinants of health data at the point of care to improve these outcomes. Now I will jump into a live demo of the application so that you can see this in live form. What you will see is a test patient. Are you able to see Health Equality?
Yes, we are.
Perfect. So this is looking at Health Equality, the initial page once a patient is searched. Again, this is test patient information. So when a care coordinator is and within the application, they are able to see the clinical gaps in care, the status. They are also able to see social concerns. So these are the Z codes that we receive from across the community, as well as pre-visit planning data. So the idea is they are able to see the gaps that are outstanding or have been met by the data that we receive from the community, as well as see if the patient has any social concerns that would be need for a referral or further care coordination. So jumping back into our presentation for some final remarks. Again, that workflow is where the clinical staff searches the patient within Health Equality. The staff is able to review those gaps in care, as well as look at information that may be presented to further conduct patient outreach. Once that information is found, the staff is able to go within Healthy Link's patient record lookup and then transfer that documentation into their EHR. Some of the key accomplishments and outcomes, we were able to expand the capabilities to support these health centers to provide the data that is needed for quality improvement. We also demonstrated that we are able to expand to additional health centers that have the capability to use the application. We increased the data collection capabilities by aggregating and analyzing the provider and the data sources, as well as being proven that this is a flexible application that can include a variety of clinical and SDOH data to support various VP initiatives. This is just a display of some of the improvements that our health centers have seen by using our application. Many of them reported increase in gap closures for their cancer screenings and improved hemoglobin A1C and blood pressure metrics. Lastly, for sustainability and innovation, we really designed the Health Equality as a long-term program that can be flexible to include various clinical data and be used for various VBP arrangements and contracting. With the additional measures and insights, the health center staff was able to work towards improving their clinical scores, as well as really make a move to increase the revenue generated by closing the gaps that are presented through our application.
Okay, well, I am Fred Rockman. I'm a pediatrician and CEO of Alliance Chicago, and I'm really thrilled to be representing the team and discussing our REACH project. The REACH project was inspired by the experience of both our health center care teams and patients, both of whom really want to improve health status, but are challenged by the limitations on opportunities for communication in the current healthcare setting. And our dream was to use technology to increase opportunities and create time. The goals of our project mapped to the HRSA quality framework. We wanted to improve adherence to evidence-based recommendations, both at patient and population level, and identify and address social determinants of health that contribute to those outcomes, while improving the patient experience and the care team experience, and increase access by improving financial and efficiency of the financial underpinning and efficiency of the care delivery, and at the same time create opportunities for our populations and communities to create the content. We focused on breast cancer screening, colon cancer screening, immunizations, and hypertension as areas where we saw biggest gaps between current status and the goals of Healthy People 2030, and aimed to leverage chatbots to improve patient access to relevant information and screen for social determinants of health. The project was led by Alliance Chicago. We're a health center controlled network with decades of experience in informatics, data analytics, implementation of health information technology, and collaborative learning and workflow redesign. And all of that in alignment with our mission to improve health at personal, community, and public levels, leveraging innovative collaboration. Our health center partner was Settlement Health, who cares for more than 12,000 patients in the East Harlem neighborhood of New York City. I'm sorry? Can you hear me?
Yes, we can. You can continue.
Sorry about that. The majority of whom identify as racial and ethnic minority, and a large percentage of whom are best served in another language. And our technology partner was ClickSoft, who had developed an AI configurable chatbot technology that we could leverage to map against the content and target areas we'd identified. Our human-centered design approach both imported a learning health system model of iterative, data-driven design cycle of design, and focused on automation as a means of introducing standardization, promulgating checklists and reminders, and including alerts where it was important to invoke human interaction by the care team. And underlying all of this, an ability to have a redundancy in communication that would not be practical if we were relying only on real-time human interactions. We convened care teams and patients to map out, design, and configure algorithms for conversations that could be programmed into the chatbot to deliver interactive scripts that mapped against the content that we focused on. The result was that the chatbot actually became a member of the care team that could create opportunities and time for patients to interact and gain access to information and provide information and access information related to social determinants of health, and to tee up more efficiently where it was important to reach out and actually involve the care team. We were thrilled to be able to follow this project through 3 phases. In phase 1, to develop the concept prototype. In phase 2, to design and deploy the first chatbot for breast cancer screening that included social determinants of health screening. And in phase 3, to scale up to cover additional content areas, as we discussed: breast cancer screening, colon cancer screening, pediatric vaccines and well child care, blood pressure monitoring, and refine the social determinants of health screening to focus mainly on food insecurity, insurance, and transportation. Overall, we were successful in engaging 1,630 patients. The target ages of the patients were 2 months to 70 years. Obviously, with children, we were working with the caregivers. And we achieved a 24 to 29% engagement rate across all the cohorts. Of those that were engaged, 36% requested some degree of care coordination assistance. The social determinants of health screening, we were successful in reaching 58% of patients who identified needs. The bulk of those were in food insecurity. And we believe that this increased rate of social determinants of health screening was related to the ability of the chatbot to deliver the screening in a more private and a more contextual manner.
Well, thank you. I'm Beth Robel, and I'm CEO of HealthLink, and I'm going to talk today about addressing the social determinants of health here in Northern Indiana. So if you've been around the healthcare world or health center world, you see one health center, you've seen one health center. We're spread across the northern third of Indiana. I said the North Shore of Indiana. We go from Chicago all the way over to the center part, and we have just a wide variety of health centers. We have one, the HealthLink in Knox, is very rural. Here's just a snapshot of some information on our patients. The one thing I really want to talk about that plays into it, last year we saw 42,550 unduplicated patients. But when it comes to screening, we only screen through the Prepare tool through our Freesia tablets, 2,972. And you might say, why so low? Well, part of the problem is Indiana Medicaid does not pay for community health workers. And if you're going to screen, you're going to have to do something about them. And having a community health worker is what you really need. And I'm going to talk today on how we use this project to look at how do we leverage the information that we can have and to increase the number of encounters that our community health workers can actually do. So to do that, I'm going to talk about the story of PAM. It's the patient activation measure, and that is an evidence-based measure survey that indicates for patients their ability, their knowledge, their skills, and their confidence to actually manage their own healthcare. And we will know it. It's also a story of one doctor, 2 patients, 1 community health worker, and the program called PAM. And you can see Rosaria is our community health worker. She's been with us a couple years. She was assigned to both Susie and Frank. And here's why. We have a doctor. We call her Dr. Beth. She actually went to IU School of Medicine, where she worked with HealthNet, another health center. Then she got her family medicine residency at Duke University, and that was where she got to go to Lincoln Community Health Center. She knows this population. And in 2019, we did our yearly provider stay interview, and she said she loved her patients, but in came COVID. And during COVID, she had 3 of her patients die. It really took a toll on her. So that in 2022, she said, I'm burned out. All my patients are non-compliant. So fast forward to this morning. She comes in, she sees 2 patients on her schedule, our little Susie and Frank, and she almost wants to walk out. I can't do this anymore. She's heard from our CFO that we can't pay for community health workers. We have some, but she's got to really be careful in how she uses it. Well, just so happened, Rosario was standing next to her and said, let me try. So this is what happened, and this is our flow. We've already screened these patients through our Freesia tablets using the Prepare. Some of them that we screen are negative, so they don't need any social interaction. We're going to come back in a year and do that. But these 2 patients screened positive. And as I said, we had one, Susie, who was a 1. She can't manage her own healthcare. So Rosaria is going to have to step in. We had Frank. He was a 4. We can actually send digital messages and then follow up to make sure that he actually got it. So here's what actually happened. You know, the community health worker went and met with Susie, actually called her or met with her at the clinic and went in and continued to help her make sure she goes to the housing. And then in East Chicago with Frank, she also helped. All she had to do was find health, and he was good with that. So here was the outcome. We actually figured through the project that we increased the amount of time that our community health workers had by 42%. With staffing shortages, this is amazing. Again, Indiana Health Medicaid does not pay for this, so we have to find a way. So she met with Dr. Beth. Dr. Beth reported, like, now I know why my patients are that way, and was a lot more happier from that interaction. So how do you sustain this? Well, our plan is to integrate PAM more into operations. We really think that our providers and everyone in the clinic understanding that this can really help them and give them more knowledge into the patient is great. We plan, and this was kind of one of our sad moments, is we really thought we would get PAM right in our EHR so it would be known for everyone to see. That did not work. We thought with the 21st Century Cures Act, this would be there. It wasn't. We're also going to expand PAM to more patients. We're on ACO REACH. We think that Medicare population is perfect for understanding. And then we feel that now that we have more time, we can then screen more patients with PAM and get more information. So with that, I will open myself to questions.
So hello, everyone. My name is Dr. Brianna N Conor. I'm the Chief Clinical Officer of Forward Leading IPA, or FLIPA. We are an integrated delivery network in upstate New York. We have health centers, behavioral health organizations, and a rural health network across a 27-county region. We are mission aligned that helping an individual's physical health needs, mental health and substance use or behavioral health needs, and social care needs is really critical, and that failing to meet the needs in any one of those areas really causes challenges in the other two. And we also know that no one community-based organization can adequately meet all of those needs, and so partnership is really critical. Our innovative solution is IACT, the Integrated Acute Contact Team. This has really, over the course of this challenge, become our standard of care across our network for how we approach integrated care coordination. It leverages risk stratified cohort management, where we use our data to identify individuals potentially in need of this service, some standardized, operationalized care coordination protocols, and operationalizing how we operate or how we function as a shared treatment team between our primary care health center and our behavioral health organization, and really bring those two teams together to meet the needs of the individual that they prioritize as most important to them. Use some minimal barrier removal funds to reduce those that we can for those individuals. And really the kind of secret sauce is that our primary care coordinator, behavioral health care coordinator are, along with their associated clinical teams, serving as a shared treatment team for the patient and meeting the breadth of their social care needs or other kind of healthcare needs as they indicate. This is a barrage of key features of IACT for you. I mentioned some of them, but one of the underpinnings here is that we use an integrative standards of care. So this is being trauma sensitive, culturally responsive, using best practices and evidence-based where appropriate for outreach and engagement strategies. And those strategies are equivocally sustainable because they can be administered by a number of different roles and functions: a community health worker, a peer, a care coordinator, care manager. Whoever comes to those meetings is able to deploy these standards and these practices. We have found that cross-discipline learning is really critical. So our primary care teams are learning a lot about harm reduction and substance use care, and our behavioral health teams are learning a lot about how to talk to their patients about their diabetes and their hypertension. So it's just really been really meaningful learning. Some of that learning that we standardized in phase 3 is what we call our IACT playbook. And these are our materials, the what are you getting yourself into for our health centers and our BHOs about the staff training, what is our homegrown integrated acute needs identification tool, what's our workflows and some of our processes to support efficient case conferences. One of the key innovations of this work that we have found is that it's removing barriers both for patients and for staff. From the patient's perspective, our INE, our identification of their needs, is a conversation, not a checkbox. It's sometimes takes up to 30 days to really find out what is important to you. Are you in pain? Do you have a prescription need? Are you currently in withdrawal, actively suicidal, don't have enough to eat? What can we help with? We have barrier removal funds. Those are some examples there of what have actually been removed in terms of barriers or helped. And that constant conversation between the two teams really helps in those transitions of care moments when someone goes from intensive specialty behavioral health care to maybe med management and primary care at the health center, to make sure that there's a bridge and that person doesn't fall through the gaps. On the staff perspective, some of what has been reduced is the voicemail lockup, I guess. So calling the front desk and getting stuck kind of in a voicemail loop of trying to figure out how to help your patient. By having consistent communication between the two teams, they're able to reduce that and really share what they know about a patient, what's meaningful to the patient, to help make that engagement more meaningful. We have some quantitative impacts that we've also found across the phases of this work and earlier phases. Our INE tool is identifying a number of needs for individuals, over 5 on average per person. In the 2 yellow boxes, when those needs are referred for other linkages and supports, they are being met within about 2 weeks. Long-term, we're reducing social determinants of health needs as measured by the PREPARE. This one is particularly meaningful for our sustainability and scalability. We have found, compared to the 6 months before IACT to the 6 months after enrolling in IACT, our patients are not only engaging more in both their medical and behavioral health outpatient services, but likely related, are also decreasing their inpatient and ER utilization pretty substantially. We have, particularly in the scaling phase, learned quite a few lessons as well. Having that documentation, that playbook, has really been critical, again, for organizations knowing what they're signing up for and what is the thing that we're doing that is consistent across our network for our patients. Having champions, both at the care coordination level and the leadership level, is really critical. Workforce shortages being what they are, that's caused some hiccups here and there. We also know that the patient plays a really critical role. Patient consent and data sharing between organizations, even in a network, is hard. And sometimes those phone calls to patients to say, hey, can we help you, are not welcome, or they don't welcome the communication between their primary care doc and their substance use treatment team. And perhaps the more frustrating piece for us all has been that our systems and our communities don't have sufficient resources to meet all the breadth of the needs of our patients, particularly in our rural communities. There is not enough housing. There are not public transportation options to meet some of these folks' needs. So that has been a continual frustration. What we have been able to accomplish is we are successfully active in 3 different communities and planning and development in a number of others. We are actively writing grants for this work that is not currently reimbursable, and continuing to advocate with the state and other managed care entities within our value-based contracts to try to find additional funding and longer-term sustained resources for the work.
Good afternoon, everyone. My name is Ted Grain. I'm the Director of Social Determinants of Health for Eskenazi Health Center, and I'm joined here by my colleague, Tiffany Arnold. We are excited to talk to you about a project called Community Weavers in a Health Equity Zone. But first, let me welcome you to Indianapolis. So if you can see this map, this is a map of Indianapolis. It's actually Marion County. And if you see the darker areas are the areas that are more socially vulnerable. We are lucky that we've had great leadership at Eskenazi Health Center for a number of years with Dr. Dawn Hout and Mindy Rosa. And we've strategically located our centers in the places that I think are needed the most. So you can see those little blue dots are our centers. We have 14 different locations, and they're located in some of the areas that need us the most. But as we were thinking about deepening our work around social determinants of health, and particularly improving health equity, we came up with a larger neighborhood-based, place-based strategy that we're calling health equity zones. Ultimately, it's taking the person-centric approach that Eskenazi Health does really well, and it builds off the healthcare center that are already, as I said, strategically embedded in neighborhoods. And it creates a shared place, a shared space that we call the health equity zone, which is an area around the center with very intentional partnerships with the neighborhood, and particularly with a community-based organization that we call the neighborhood convener. Essential to this approach is a new understanding of the staff. So we have the social work team that does a great deal of social determinants of health work. We then have the community health workers going even further upstream, going into people's homes. But we've now created a new position, and that's really the position that we're piloting here with this effort, that we call a community weaver. The community weaver sees the neighborhood as the patient and is really connecting the healthcare center directly to all the neighborhood partners and leveraging those partners' assets. So we went through an exhaustive process to select 3 different neighborhoods in Indianapolis, the International Marketplace, the Northeast Corridor, and the Far East Side. And so far, what we've done is lead a planning process that we've had over 500 people participate in to identify the top needs for health equity in those neighborhoods. And now I'd like to introduce my colleague, Tiffany Arnold, who leads our Community Weaver work.
Hello, everyone. So a lot of people ask, what is a community weaver? A community weaver is a health concierge. They are a trusted member of the community. They understand the needs of the community. They identify where they need to be to get closest to the people who live in the communities. So far, we have been able to develop training for our community weavers. We have marketware where we document all of our interaction or activities. Our community weavers also use our electronic medical record system, Epic. We have 8 community weavers that are working with us as well as a supervisor and a project manager. We have a workflow. We communicate with our community health workers and our social workers. Each weaver creates an asset map and a work plan, and then we go out and we support our health equity zones. these are just some of the activities that we've done from April 22. As you can see, we continue to grow the activities that we're doing. Although a lot of it is that community connectedness, we have to do that because we have to really learn the organizations in our areas, meet with them, be available to them, complete outreach with them. But we also touch on those other SDOH issues: housing, economic opportunity, and food. So I like to end today with a success story. I had a weaver that was out at a pantry doing outreach and ran into a 64-year-old African-American male. This man needed assistance with his rent. He was really struggling. After engaging with him a little further, we found out that he was the sole caregiver for his wife. His wife was disabled and needed services as well, but he did not know what to do to help her or to help himself. Being that he was 64, we were like, hey, he might qualify for Social Security. So we connected him with the Social Security office, where he was able to not only apply for benefits for himself, but also apply for benefits for his wife. Then we were able to connect him to an organization that helped him get Medicaid waiver for his wife, which allowed for those home health services. Afterwards, he just really said, I want to work. I want to be able to be the man of my house. And so we were able to connect him with Goodwill, that has a senior employment organization. And we got him an application mailed directly to his house. He was very satisfied, and being able to help him right there on the spot was very rewarding. And we have follow up with him every time we attend this outreach.
So in closing, we have 10 seconds. Sustainability ultimately relies on a future value-based care model. But in the meantime, we have found that we have found a lot of philanthropic support. And additionally, we feel like this model prevents a lot of the activity that otherwise would clutter up a practitioner's time with the patient and really frees them up to be doing more work at the clinic. So thank you very much, and happy to entertain any questions.
Hi, everyone. Thank you for this opportunity to talk to y'all this afternoon. I guess we're the caboose here of the presentations. We're Target Health, and we'll be presenting on our behavioral health integration model and our experience scaling this model through our participation in the Challenge Grant. Target Health has been in business since 2016, and we partner with health centers across the state of Louisiana. Our care coordination team consists of registered nurses, licensed practical nurses, and community health workers. This model was initially developed as a pilot in collaboration with one of the Louisiana Medicaid managed care organizations. The pilot was launched in 2019 and consisted of 4 federally qualified health centers. Here we present outcomes from 3+ years of data from those clinics that we have collected. Based on the pilot, we developed the behavioral health integration model we see here. Target Health and health centers partner to identify eligible patients by screening individuals using the Prepare assessment tool. Target Health staff conduct an outreach calls to identify patients' needs and then refer them as needed to community-based organizations. Target Health staff then follow up to ensure that the need has been met and to close the referral loop. To achieve these goals, we had bi-monthly phone calls and on-site visits with each of our participating clinics. This model allowed us to meet the specific needs of each clinic by including the provider's scheduling preferences and also integrating with each of their EMRs. This map shows locations of our clinics alongside the prevalence of high blood pressure. Areas of dark red represent high rates of diagnosed high blood pressure, and the green diamonds indicate all of our participating clinics across the state. Likewise, we present clinics alongside the prevalence of diagnosis of diabetes. Here, areas of dark blue represent high rates of diabetes, and the red squares indicate our participating clinics. Finally, we present parishes by percentage of poverty. Areas of dark blue indicate the higher rates of poverty across the state of Louisiana. So what was the impact of our model in these clinics? What did the experience look like, and how did we impact their patients? When we look at the experience of scaling from phase 2 to phase 3, we see a clear success. 900% increase in calls made from phase 2 to phase 3. This demonstrates the strength of the model as we scaled to a larger number of clinics and a much larger population. We had a 50% success rate in phase 2 and improved to a 67.1% success rate in phase 3. In phase 3, we further added clinical outreach, targeting those with uncontrolled hypertension and diabetes. These calls encouraged individuals to come in for their primary care appointments, provided education around their disease, and reminded patients to bring with them any medication and self-management tools that they were using. Since March of 2023, we were able to schedule 11% of those patients for an appointment. These calls assisted in engaging patients with their PCP, provided otherwise they would not have had an appointment. These patients will now receive important routine care and will generate additional revenue for the clinic by increasing their visit volume. A third-party evaluator spoke with 4 of our participating clinics to discuss the impact of on their population. Please see their feedback here. The reason we feel we achieved this positive feedback from the clinics is told here in the numbers you see. We reached many patients that were not previously having these types of conversations with their providers and helped them address issues that were not previously identified. Due to the high number of patients that we successfully reached, our care coordination team was able to assist patients with more referral needs and, of course, to close the referral loop. This model allowed our care coordinators to touch the lives of so many patients that were facing many difficult situations, such as housing, food, utilities, and work. This slide shows the top 4 needs that our patients had that we served. As we noted earlier, in our experience with the pilot program, it took approximately 1.5 years to see impactful changes in health outcomes. We expect to see something similar in this larger population. We present here clinic baseline data that we have gathered during phase 3, which is compared to HEDIS and UDS national metrics. We will continue to track this data as we continue this great work. Final thoughts. Due to our success, we've established a nonprofit foundation, which we will use to address the needs we have identified through this great work. We can use this data to tell a compelling story to lawmakers and policymakers. We can also use our platform to elevate the needs of those in our rural communities. We have built new relationships and strengthened old ones with our state's Community Health Worker Network, State Office of Rural Health, and Second Harvest. Where do we go next? The expansion continues. As this model continues to expand, we expect to see new payer contracts in place and additional clinics participating in this model. We look forward to continuing the positive impact in lives in Louisiana.
Hello, everyone. My name is Veronica Roa, and I'm a public health advisor in the HRSA's Office of Intergovernmental and External Affairs, and I co-led this challenge competition. As you saw from our selected winning solutions, our multi-phase competition reflected a close collaboration with the wide range of public partners. These partners successfully leveraged technology, partnerships, and community engagement to enhance access to care and improve care coordination. HRSA remains strongly committed to advancing our mission through innovation and collaboration. And now I want to thank my dedicated team in the Office of Intergovernmental and External Affairs and the Bureau of Primary Healthcare, as well as our external advisors and our distinguished federal judges for your hard work, time, and commitment to this effort. And lastly, a huge congratulations to our 8 amazing winners. We hope that you found this webinar inspiring and that you will visit challenge.gov, again, challenge.gov, for more details. And moving forward, please consider staying connected to HRSA to support the adoption and scaling of our winning solutions in your communities. Have a wonderful day, everyone.